Painkiller addiction is insidiously sweeping the nation. I say insidiously because even though many of us see evidence of this prescription painkiller addiction, we only see the tip of the iceberg. Back in March of 2008, SAMHSA announced that Oklahoma led the nation in painkiller addiction. They identified some 6.7% of the population, 12 and over, use painkillers. Now this is far beyond epidemic proportions. And they have also estimated that the national average of painkiller addiction is well over 5%. So we are looking at a huge volume or mass of our population that are addicted to painkillers. Now what has caused this is the cheap and easy access to these prescription painkillers through online illicit pharmacies. These online illicit pharmacies make it possible for people to get the drugs and get them somewhat inexpensively so that they can maintain their addiction at the same time that they're maintaining their job, maintaining their household, maintaining their families. But when that cheap and easy access to drugs is shut off, then what's going to happen is people become sick and desperate in a hurry. Now, what's happening is that the DEA is beginning to shut down these illicit online pharmacies. In addition, the Senate has passed the Ryan Haight Online Pharmacy Act. So what we can expect is for an abrupt shutdown of this main supply that has fueled this national epidemic. What's going to happen then? Well, it's pretty foreseeable progression of ramifications. First, people are going to start losing their jobs, encountering the criminal justice system. When they lose their jobs, guess what happens next? They lose their housing because they can't pay the rent. When they lose their housing, what happens to their families? Well, child welfare gets involved. So what we're looking at here is a whole plethora of flooding or a tsunami about to hit our social services, healthcare services, our criminal justice system, and behavioral health services all at once. And that's going to happen against a backdrop of underfunded services in place. Have you tried to get someone in inpatient detox lately? It doesn't happen. There's a waiting list in Oklahoma on any given day that ranges from 1,000 to 1,300 people for residential treatment for substance abuse. Now what we've also know is that traditional forms of substance abuse treatment do not work well for opioid addicts or people who are addicted to painkiller and or heroin addiction. So here we are at the cusp of a great tsunami about to hit of various problems, and we don't have the capacity to deal with it. But SAMHSA has identified evidence-based best practices, which include Tip 43, the medication-assisted treatment, that allows us to skip inpatient detox, skip the bottleneck to accessing treatment. And that is going to be key to addressing this issue. Now, what medication are we looking at with this medication-assisted treatment? There are the new generation drugs, the buprenorphines, which include Suboxone. While these drugs are quite effective, the problem with them is they're quite expensive. And many of the public-funded insurance, like Medicaid, don't cover those costs. A lot of private insurance don't cover those costs as well. So what we have is a situation where the buprenorphines aren't going to be available to a large percent of the population that's heading over this precipice and into these foreseeable progression of destruction. So what we have to look at is an old standby, methadone. Methadone has been around for over 30 years in treatment of opioid dependency, and it is rigorously well-tested medication that is safe and efficacious for treatment of narcotic withdrawal and dependence. Opiates like heroin and prescription painkillers release an excess of dopamine in the body and causes users to need an opiate continuously occupying the opioid receptor in the brain. Methadone occupies this receptor and is a stabilizing factor that permits addicts on methadone to change their behavior and discontinue heroin or prescription painkiller use. Taken orally once a day, usually in the morning, methadone suppresses narcotic withdrawal for between 24 and 36 hours. Its effectiveness in eliminating withdrawal symptoms makes methadone useful in detoxifying opioid addicts. Methadone is not, however, effective in cases of addiction to other drugs. Methadone reduces the cravings associated with these opiates and blocks the high from those opiates, but it does not provide the euphoric rush because of the longer half-life of methadone in the blood system. Consequently, methadone patients do not experience the extreme highs and lows that result from waxing and waning of heroin and painkillers and blood levels. Ultimately, the patient remains physically dependent on the opioid but is freed from the uncontrolled, compulsive, and disruptive behaviors seen in heroin and other opioid addicts. Lifestyle changes can be made that support the maintenance of healthy and responsible living. The Oklahoma Department of Mental Health and Substance Abuse Services reports that heroin accounts for only 5% of the substance abuse treatment admissions, yet that 5% account for nearly 26% of criminal justice involvement. Addiction to heroin is highly correlated with criminal activity. That type of environment affects many areas of living and in a manner that is detrimental to the addict, to society, and to society as a whole. By removing the need to access that element in order to obtain drugs, whether heroin or diverted prescription painkillers, that allows the opiate addict to pursue a different course of life that benefits the addict, benefits their families, and society at large. Withdrawal from methadone is much slower than from heroin, and as a result it is possible to maintain an addict on methadone without harsh side effects. Methadone maintenance treatment provides a heroin addict with individualized health care and medically prescribed methadone to relieve withdrawal symptoms, reduce the opiate cravings, and bring about a biochemical balance in the body. Important elements in heroin treatment include comprehensive social and rehabilitation services. Now the question is methadone safe? Like any controlled substance, there's a risk of abuse. When used as prescribed and under a physician's care, research and clinical studies suggest that long-term methadone maintenance treatment, or MMT, is medically safe. When methadone is taken under medical supervision, long-term maintenance causes no adverse effects on the heart, the lungs, the liver, the kidneys, bones, blood, brain, or other vital body organs. Methadone produces no serious side effects, although some patients experience minor symptoms such as constipation, water retention, drowsiness, skin rash, excessive sweating, and changes in libido. Once methadone dosage is adjusted and stabilized or tolerance increases, these symptoms usually subside. Methadone is a legal medication produced by licensed and approved pharmaceutical companies using quality control standards, prescribed by specifically licensed physicians, and administered by specifically licensed clinicians, all of which are under close regulatory scrutiny. Under a physician's supervision, it is administered orally on a daily basis and strict program conditions and guidelines. Methadone does not impair cognitive functions. It has no adverse effects on mental capability, intelligence, or employability. It is not sedating or intoxicating, nor does it interfere with ordinary activities such as driving a car or operating machinery. Patients are able to feel pain and experience emotional reactions. Most importantly, methadone relieves the craving associated with opiate addiction. For methadone patients, typical street doses of heroin are ineffective at producing euphoria, making the use of heroin and other painkiller medications less desirable. However, there are differences among clinics' internal policies and procedures that can make drastic differences in the safety of the patient. I want to talk with you for a moment about some main considerations when you're considering a clinic for methadone maintenance treatment. First, find a clinic that uses liquid methadone, dispensed on site and that cannot be cheeked and diverted. Studies show that diverted methadone, often sold in the streets, is responsible for the majority of methadone deaths. Daily dosing on site and not allowed to carry home allows for clinical assessment of their speech, their gait, the patient's eyes, etc., that prompt clinicians to order urine tests. Now, these urine tests need to include a 12-drug panel and test also for adulterants or masking agents, which are used to flush the system of drug traces. Now, you may be able to flush the system of drug traces, but the metabolites that result leave a trail, and we can detect those. So the rampant use of such masking agents makes many tests yield false negatives. Unless a program tests for such adulterants, their patients are at risk. Now, the second thing we want to look at are strict and limited carry-home doses, and that prevents misuse of the drug or diversion to the streets. Carrying multiple doses home allows for self-administration of the drug, which can result in not taking the drug as prescribed, which means overdosing, or diversion of the drugs being sold on the street to the street market. Since methadone potentiates many other drugs, it has a street value. And thirdly, the supplementation of the methadone regimen with other drugs. Since methadone potentiates many other drugs, this represents a serious risk of drug interaction. Now, the third thing that we want to look at here when we look for clinics is a mandatory psychotherapeutic treatment of the underlying addiction. To maintain people on methadone and not treat the underlying addiction almost sets up a clinical expectation of relapse. So we want to treat the underlying addiction in order not to place the opiate addict being maintained on methadone at significant risk of relapse while on a medication that potentiates other drugs. The fourth thing that we want to look at is accountability to prevent doctor shopping while being maintained on the drug, or in other words, multiple dosing. Every program should participate in the DEA's prescription drug monitoring program and fax sole provider letters to all other opioid treatment programs in the state to confirm that they are, in fact, the sole provider of medication-assisted treatment. Programs that utilize these safeguards protect the addict from him or herself. Now, are there benefits to methadone? Well, we have identified several benefits to methadone maintenance treatment. But the data demonstrates that continuous methadone maintenance treatment is associated with several other benefits. First of all, methadone maintenance treatment costs about $13 a day and is considered a cost-effective alternative to incarceration, which is a specific alternative to heroin addiction with the fivefold overrepresentation in the criminal justice system here in Oklahoma. MMT is more than pays for itself with a benefit-to-cost ratio of 4-to-1, meaning that $4 of economic benefit accrues for every $1 spent on MMT. MMT has a significant effect on the spread of several serious diseases such as HIV or AIDS infection, hepatitis B and C, tuberculosis, and sexually transmitted diseases. Heroin users are known to share needles and to participate in at-risk sexual activity and prostitution, which are significant factors in the spread of many diseases. Research suggests that MMT significantly decreases the rate of HIV infection for those patients participating in MMT programs. In 1998, a study for the National Institute on Drug Abuse found that among outpatients receiving MMT, weekly heroin use decreased by 69%. The decrease in use allows for the individual's health and productivity to improve. A life of crime was no longer required to support their habit. Criminal activity decreased by 52% among these patients. Full-time employment increased by 24%. In 1994, a study of drug treatment in California, researchers found that rates of illegal drug use, criminal activity, and hospitalization were lower for MMT patients than for addicts and other type of drug treatment programs. In conclusion, MMT is one of the most monitored and regulated medical treatments in the United States. Despite the long-standing efficacy of MMT, only 20% of heroin addicts in the United States are currently in treatment. The consensus panel recommended expanding the access to MMT by increasing funding. If you'd like to find out more about MMT, methadone maintenance, I would like to recommend that you go by http://methadone.web.officelive.com or call one of our 3 treatment facilities in Oklahoma City, 405-672-3033, or in Tulsa, 918-770-8550, or in Miami, Oklahoma, 918-542-1786. There is hope to meet the emerging painkiller addiction tsunami crisis, but we as communities need to plan our community responses and plan them now. If you would like to have Dan Cross speak at your organization or conference, please call area code 918-260-1096.